We are going to discuss about the abdominal X-ray interpretation. First, I will go through a normal anatomical structure like stomach, small and large bowels, soft tissue like spleen, kidneys, liver, and bladder. Then after that, we're going to go to the pathology, the common acute abdominal pathology like intestinal obstruction, perforation, calcification, renal calculus, and other classification also along with foreign bodies. So first, before you start reporting the abdominal X-ray, first we need to make sure patient's detail, like KI number, name, so that to make sure that you are dealing with the right patient. Then after that, you need to make sure which projection has been used. The standard abdominal X-ray is AP supine projection. AP, it means that the X-ray passes through the patient from front to back, with the patient lying supine. Yeah. So this is the standard abdominal X-ray, which is the AP. So what I mean abdominal X-ray, so I mean it needs to show all from the diaphragm here, till symphysis pubis. Why from the diaphragm? Because if there is any, like, to see if there's any free air, and also liver, spleen, to the symphysis pubis to see the bowels and bladder. What is the indication for the abdominal X-ray? Suppose if the patient come with the acute abdominal pain, when you suspect abdominal obstruction, suspect perforation. Although perforation, I mean the sensitive image for the perforation is the erect chest X-ray, yes, to see the free air. But for patients who's critically ill, cannot stand or in erect position, still abdominal AP view can be helpful, so that it will see, show a couple of signs we're gonna discuss later on. And also if there's if you suspect colitis, to see if there's any like signs of the toxic megacolons, and also for foreign bodies and tubes. Yeah, so these are indications of the abdominal X-ray. So the anatomy, when you start reporting the abdominal X-ray, start with the stomach. Okay, so this is the stomach. So the normal stomach mucosa shows rugae. So this is rugae, yeah? Rugae, which is a thick, irregular folds in the fundus and body, yeah? This rugae flatten when the stomach is, when the stomach is distended after eating, drinking, or with swallowed area. Otherwise, you're gonna see this rugae. But it will be flatten when the stomach is distended. So let us see. This is another one. This is another normal stomach mucosa. This is the normal stomach contains air. Look, if the stomach contains air or distended with the eating, after eating or drinking, you're not going to see a rugae. So this stomach contains air. It may be visible in the left upper quadrant of the abdomen, and the lower part of the stomach crosses the midline. So this is the normal stomach. Let us just discuss one of the picture of the abnormal stomach. Then we will go to the normal gas pattern of the small and large intestine. So if you come with this X-ray, so this X-ray demonstrate this distended stomach. This is distended stomach and a few of bowel gas. Look, if you see a few of bowel gas, elsewhere, here, there's a few small, few of bowel gas elsewhere. So this patient has gastric outlet obstruction. If you see, in this case, the obstruction is probably just distal to the stomach. Why? Because as you see, there's a gas still in the duodenal gap. Yeah. So this patient has distended stomach, and the probable obstruction is at the here, at his chest, distal to the stomach, because there's still gas in the duodenal cup. So this is one of the case of the gastric outlet obstruction. So what is the common cause of the gastric outlet obstruction? Which is the peptic ulcer, yeah? And there is a peptic ulcer. So the late stage of the peptic ulcer will undergo to the scarring, pyloric stenosis, and the patient presents with such manifestation. And also malignant cause like pancreatic and gastric tumors, so as well as also metastasis. Here, if you see, bowel gas pattern, let us see, the normal bowel gas pattern. Do you know, if you know the normal appearances of the bowel, it will really help you to determine the abnormal one, and also, the location of the abnormalities. Yeah, so it's very important to know the normal gas pattern of the small and large bowel. So here, so the normal, as you all know, normal small bowel is usually, the gas of the normal small bowel is centrally located, yeah? And the mucosa of this small, let me just into one of the, this is one of the small bowel, just in closer so that to know the normal mucosal fold of the small bowel. So usually a small bowel located central, yeah? So the position is central on the abdomen. And the mucosal fold of this small bowel, which consists of the valvular convenience. Valvular convenience mucosal, which is the mucosal fold that crosses the full width of the bowel. If you see this mucosal fold crosses the full width of the bowel. Yeah. So this is one features of the small bowel, and also the diameter of the small bowel need to be less than 3 centimeter. If you heard the rule of 3, 6, 9. So the diameter of the small bowel and normally less than 3 centimeter, and large bowel need to be less than 6 centimeter. Cecum less than 9 centimeter. So the normal features of the small bowel centrally located, okay? So centrally located, and the valvular convenience, and also need to be the diameter less than 3 centimeter. So this is the normal appearance of a small bowel, okay? So this, as I said, this is one of these. This is a very, scanty gas in the small bowel. Here, this is another features of this small bowel, which is very scanty because they're normal, so it's a very scanty small bowel. This is one of the, just in the closer way. Here, if you look at the large bowel, how you're going to differentiate small bowel to the large bowel? Large bowel, it's peripherally located. Look, if you look at here, this is the cecum, then it will go ascending, and then transverse colon, and then hepatic flexure, and then it will come down as descending colon. Okay, so large bowel, peripherally located. So the position of the large bowel is peripheral in the abdomen. And the shape of the large bowel is hastra. When there's just like this circulation here, and the mucosal fold of the large bowel is incomplete. If you look at here, the mucosal fold is incomplete, opposite to this small bowel. The small bowel, it was extend or cross the full length, but here it's incomplete mucosal fold, which form as circulation, or what we call it hastra. Yeah. And the diameter of the large bowel should be less than 6 centimeter normally. Okay. So the features of the large bowel, peripherally located, and from it is the mucosal fold or shape hastra, which is incomplete mucosal fold, and also the diameter need to be 6 centimeters, less than 6 centimeters. Okay, so the large bowel, I mean that one. Usually, if you look at it, it's a variable in position. If you see ascending colon, this is ascending colon, because ascending colon and descending colon and rectum are located retroperitoneal, retroperitoneal. That's why they are relatively constant in position. But transverse colon or sigmoid colon are more variable in position, because in contrast to the ascending and descending and rectum. So as we said, cecum is the widest part of the large bowel, can extend up to even 9 centimeters, and the rest of the colon 6 centimeters. Okay, so so another feature of the large bowel, it contains feces. If you look at here, this is this feature. How you are going to know this is a large bowel? Because the large bowel also contains feces, so it will give appearance of mottled appearance. So this is mottled appearance. Where's the why it's mottled appearance? Because the feces mix it with the bowel gas, so it gives the appearance of mottled appearance. Okay, so here it is. So how did I know this is the large bowel? So the large bowel is peripherally located, and it is diameter. If you look at it, it is definitely. I mean, it's more than 3 centimeters. Yeah, so it is up to the 6 centimeters, and it is contain feces. Feces mixed with the gas give us mottled appearance. Okay, so suppose if this patient come with the severe abdominal pain, I mean, not able to pass a bowel movement for the last like 4 or 5 days, and suppose if you're suspecting abdominal obstruction, we're gonna do an abdominal X-ray. So this X-ray came as this mottled appearance, which is the fecal impaction, give appearance of the mottled appearance. You will know at this patient, hasn't passed motion for the last couple of days. So only that management will be like laxative here. So, to sum up, so the features of the large bowel, it's a peripherally located, diameter, it's like to 6 centimeters. And if it's feces, contain feces, it will give the appearance of the mottled appearance. If it's empty, it will give the appearance of hastro, or circulation. So, and then what you're gonna see in the abdominal X-ray, other than small bowel, large bowel, and stomach, you need to look at the soft tissue. So the first soft tissue is the liver. If you look at here, a soft tissue, liver, it's located in the right upper quadrant, So the liver here lies in the right upper quadrant, and is seen as like a blunt area of gray on abdominal X-ray, So here, the superior edge of the liver forms the right hemidiaphragm, okay? So in this, if you look at here, this is the breast of the female patient, either breast, okay? This is the breast, and this is the upper margin of the liver. And here, it's the basal of the left lung, okay? And if you look at here, this is all lung markings which overlies the liver. So you're gonna see the liver, and also you're going to see, this is another pictures of the left basal lung, and this is costophrenic angle. If you see here, costophrenic angle, this is the posterior part of the lung base, okay? And this is the costophrenic angle. And then what else you're gonna see? You're going to see the here, psoas shadow. You see these shadows? These shadows? So this shadows, these two shadows, psoas muscle. Psoas muscle arise from the transverse process of the lumbar vertebrae. Here it will comes down until it combined the iliacus muscle, iliacus muscle. Then both of them will join come down until it attached to the here. Here, if you see this, lesser trochanter of the liver, of the femur. Okay, so iliacus muscle here. This is the right one, and this is the left side. So the left psoas shadow extends from the lumbar. You see, this is the transverse process of the lumbar vertebrae 1. Then it will come down and it will join the iliacus muscle at the iliac bone. Then both of them, it will run down until it attach the lesser trochanter of the femur. It's the more clear psoas shadow, just for educational purpose. Here, it will extend from the transverse process of the lumbar vertebrae coming down, and it's joined to the iliacus muscle, and until it attached to the trochanter of the femur. This is another soft tissue. What is this? This is the left kidney. You see this? This is the shadow of the left kidney. So you need to look at all of these structures while you are interpreting abdominal X-ray. So, the kidneys usually lie at the level of thoracic vertebrae 12 until L3. So this is T12, 1, 2, 3. So this is lumbar vertebra 3. So actually the kidney lies between T12 and L3. Okay. And the left kidney usually higher than the right one due to the position of the liver. Okay, so now we have looked at the also soft tissue of the kidney. This is kidney. And then what you're going to see, this is the spleen. Look, again, so this is the psoas shadow here. This triangle of the psoas shadow. And then this is the left kidney. Okay, and this one up to the left kidney, it is a spleen. So this is spleen. You have to look at all of these soft tissue because maybe you're going to see incidental findings like any calcification, any gas shadow. Okay, so this is the spleen. Okay, which is the psoas shadow, left kidney, and spleen. Okay, here then after that you're going to see the bladder. So this is the bladder. The bladder has a variable appearance. Yeah, because it depends on how full it is. So it has the same density as other soft structure. Why? Because it's water content. Okay, so this is the normal soft tissue located at the pelvis, which is the bladder. Okay, so you might see stone on it, any thickening of the bladder wall or any tumor. So you have to look and if there's any abnormalities in the bowel, in the bladder. Then after that, what you're going to see, so other than soft tissue, what you're going to see in the abdominal X-ray, you're going to see a normal bones on abdominal X-ray. So here you'll start with the lower ribs. So this is lower ribs, right side, and this is the left side. And then lumbar vertebrae. These are lumbar vertebrae. Maybe you're going to see any incidental findings. You need to comment it. Okay, so for further investigation, for further follow-up, so you need to comment. So as I said, lower ribs, then lumbar vertebrae, and sacrum. Okay, this is sacrum. This is sacrum, and this is also cox, and this is the pelvic bone. And here, if you could see, sacroiliac joint. You see this? Sacroiliac joint here. And this is the right side, sacroiliac joint. Okay, so you have to comment all of this normal anatomical structure while you're interpreting. So, I mean, if you know this is the normal anatomical structure, you will easily identify abnormalities. So, as I said, you need to comment first the stomach, then small bowel and large bowel gas shadows. We said the difference between the small bowel and large bowel gas shadows. Yeah. Then after that, I will comment on soft tissues, liver, spleen, kidneys, bladder, and also source shadow if there's any abnormalities on it. And then you're gonna comment on the bone, lower ribs, lumbar, pelvic bone, sacrum, coccyx. And if there's any abnormalities, you will easily identify it and comment on it. Okay. Now we will discuss about abnormalities. Abnormalities is the first and common and life-threatening emergency one. It is the pneumoperitoneum. Yeah. So free gas or pneumoperitoneum. So first, what's the pneumoperitoneum? It's the gas or air trapped within the peritoneal cavity. Yes. So I mean within the peritoneal cavity, but also the lumen of the bowel. So pneumoperitoneum, it's one of the features of the bowel obstruction. But at the same time, pneumoperitoneum you could see pneumoperitoneum during the normal laparoscopical procedure, like when there is CO2 insufflation, gas insufflation of the gas. So, I mean, both of them, when it is due to the bowel obstruction or due to the CO2 insufflation during the laparoscopic procedure, you will see the similar appearance, but for sure, different clinical significance. Yeah. So, how are you going to describe pneumoperitoneum? So, let us see here. If you see, this is a large bowel. Here, if you see this is large volume of the air, which is concentric, located below right diaphragm. Yes, which is here is bilaterally. Right and left, large volume of the air, concentric shape, located bilateral right and left diaphragm. Okay, this one. So, I mean, usually the sensitive X-ray projection to detect pneumoperitoneum is erect chest X-ray. Okay, but we can also see signs of the pneumoperitoneum while you are going to take the AP projection or anterior posterior projection. So there's a signs. We can do abdominal AP projection to detect the signs of the perforation for the patient who is critically ill, who's not unable to stand or erect stand. So we are going to do abdominal AP projection instead of erect chest X-ray. So let us see the signs of the bowel perforation while the patient in AP projection. So normally, if you looked at here, so normally there's a normal single layer of the bowel, yeah? Single layer of the bowel, okay? Here, if you look at here, you're going to see the appearance of this lucency. This is double wall sign, okay? This is the double wall sign. It means that a free gas in the peritoneal cavity, it will outline, where's the mouse? So it will outline the both sides of the bowel wall, so making it looks like a double line. You see? See? This is the double line, yeah? Normally, you can only see the single wall in the bowel. But here, if you see, there's a double wall sign. If you see here, so this is the free air in the peritoneal cavity outlining the both sides of the bowel wall, making it look like double wall, yeah? This is one of the signs. And there is another sign, you can see it here. Here, if you see these pockets, these small pockets of air trapped between the bowel slope. This is one of the pocket, and this is another pocket, and here. So these small pockets of the air trapped between lobes of the bowel, so creates a triangular or dome-shaped lucencies. Okay, so this is the second line. So as I said, double wall sign and triangular or dome-shaped lucencies. And also there is another sign here. If you look at here, there is a large volume of free gas, has risen in the front of the peritoneal cavity. So it gives us the appearance of the large round black area. You see this large black area. So this the entire peritoneal cavity is outlined by the free air. So this it gives the appearance of that one football, football, American football, and the super X-ray like this. Okay, so this is the large air which comes in front of the peritoneal cavity. This in this you're gonna see this appearance while the patient is lying supine, and the air is just rise up to the front of the peritoneal cavity. So we'll see this large volume of the air front to the peritoneal cavity while the patient in supine position. So this will give us appearance of the large football American one, yeah. How we're going to differentiate the left pneumoperitoneum to the normal gas shadow in the left, yeah. So suppose if it's pneumoperitoneum in the right, below the right diaphragm, you can easily distinguish it with the air concentric shape below the right diaphragm. But if there is pneumoperitoneum below the left diaphragm, how we are going to distinguish it with the normal gas shadow, because it mimics each other, yeah. So there is a feature you can distinguish both. If you look at here, so usually the normal stomach bubble zone, looks like the pneumoperitoneum. Let's see how we're going to differentiate it. Here the stomach bubble here forms round or oval shape, in either round or oval shape. Okay, so it is just below the left diaphragm. So if you look at here's a thick wall. Okay, so here the stomach has a thick wall. So that's why we're going to see thick lines separating gas in the stomach from the air in the lungs. If you just look at here, how we're going to differentiate? So this is the same. This is another normal gas in the stomach, and this is the abnormal free air, or what we call it pneumoperitoneum, under the right diaphragm. Here the normal gas shadow. So how we're going to distinguish between both? If you look at here, it is a thin line separate the gas in the lung to the free gas under the diaphragm. Here, if you look at the left side, it's a thick wall is separating the gas in the lung to the gas shadow. So this is one sign. The second sign we're going to distinguish between both, shape. So the shape of the pneumoperitoneum, which is the free air, concentric shape, while the gas shadow will be either round or oval. Okay, this looks like oval or round, thick wall. Okay, so here you can easily see it is our same oval shape, yeah, oval shape, and thick wall separating the gas shadow to the gas in the lung. So with these two features, we can distinguish the pneumoperitoneum from the gas shadow. So now we will go and discuss about the intestinal obstruction. Okay, so the intestinal obstruction. So as I said, if you know, the normal gas shadow in the small and large bowel, you will easily identify the abnormalities, which is the small or large bowel obstruction. Yeah. So here, what you are seeing here, suppose this patient presents with the features of the abdominal obstruction, like abdominal pain, distension, vomiting, no passage of the bowel more than 4 or 5 days. Yeah. And then you need to request a standard AP projection. Standard AP projection. What you are going to see here? Here you can see this. Here the distended multiple gas-filled bowel. Here the distended gas-filled bowel. So the dilated small bowel, if you measure it, it will be definitely more than 3 centimeters. Yeah. So we said small bowel more than 3 centimeter, it's abnormal. Normally, it need to be less than 3 centimeter. So here, how did I know this is the small bowel obstruction and not the large bowel obstruction? What did we say about the normal appearance of the small bowel? We said it's a vulvar convenience. So we're gonna see the vulvar convenience. Usually, I mean, it's a normal vulvar convenience. You cannot see clearly if you compare to the obstruction of the small bowel. When the small bowel obstructed, you can easily identify vulvar convenience. Here, if you look at the mucosal fold of the small bowel, or what we call it vulvar convenience, it's the complete mucosal fold, completely crossing the bowel wall. Yeah. So this is the features of the vulvar convenience, and the dilated small bowel. It's more than 3 centimeter, and also another feature is the centrally located. So with these three features, I identify these are small bowel. Here, I mean, do you know? I mean, how there's another features of the small bowel obstruction, not the mechanical one. You have the mechanical one and non-mechanical one. So the mechanical one causes, as I mentioned, due to the previous adhesion or tumor or a condition like Crohn's disease. But also we have the non-mechanical one, what we call it ileus. Yes, ileus. Ileus, it means that one, I mean, peristalsis, decrease or absent movement of the bowel. So you're going to see the features of small and large bowel obstruction in ileus. If you look at here, there is a dilated small and large bowel. So these are small bowels centrally located, and these are large bowel also can see here. So this dilatation of the small and large bowel in a patient underwent appendectomy 3 days ago. Okay, here. Have you heard about the, I mean, localized obstruction, or what we call it, sentinel lobe? So, I mean, sentinel lobe, when there is a localized lobe of the small bowel, and is dilated just in case of the inflammatory condition like in appendicitis, diverticulitis, pancreatitis. So only localized dilatation of the bowel, whether it is large or small bowel. So what we call it sentinel lobe. If you look at here, it's a localized dilatation here, the localized dilatation of the small bowel. Yeah, localized dilatation. This patient's underwent, I mean, had pancreatitis, and presented with the abdominal pain. When he had an X-ray, shows that only this localized dilatation of the small bowel. Here, if you look at here, this is a dilatation of the large bowel that extends from the cecum down up to the ascending, and this is transverse process, and this is the splenic flexure and comes down to the ascending. So this is the dilatation of the whole large bowel. Again, so this is the cecum. If you measure the diameter of the cecum here, it will be more than 9 centimeters. Yeah, so this is the cecum going up to the ascending. This is the hepatic flexure, transverse colon, and this is the splenic flexure, comes down to descending colon. So if you look at here, there's an impression of soft tissue shadow here, impression of the soft tissue shadow. This most likely the cause of the obstruction, which cause dilatation of the above of the large bowel. So this is even we see the reason of the large bowel obstruction. This is by the soft tissue shadow. Okay, so how did I know that this is the large bowel and not the small bowel? By seeing. If you know the normal appearance of the colon, you will easily identify the abnormality. So here, as we said, the large bowel located peripherally. Yeah, so this is located peripherally. And also it's the vulvally convenient. This hysteria. Do you see this? We say the hysteria, if it's only contain few gases, we'll see hysteria that circulation is incomplete mucosal fold. Here, if you see this incomplete mucosal fold here, making this hysteria, and the diameter. If you see the diameter here, the cecum more than 9 centimeter, and the colon is more than 6 centimeter. And this is the reason, and this is the cause of the obstruction. So that's why this all upper level of the large bowel has been dilated, extending from the descending up to the, you can even see the cecum, and even this is the small bowel. Do you see this? Because there is an obstruction of the large bowel due to the anatomical structure, also the small bowel will be dilated. You see here, this is also small bowel, okay? Here, if you look here, this one, the sigmoid colon, this is the sigmoid colon. If you could just trace it from here, this is the sigmoid colon. This is the sigmoid colon, is hugely dilated because the sigmoid colon has been twisted at the root of its mesentery. So this sigmoid colon, ideally, it is in the left iliac fossa, yeah? So when it becomes dilated, it will the proximal large bowel here. If you look at here, this is the sigmoid colon. It has been hugely dilated. So it's in the left iliac fossa. If you look at here, there is also the proximal of the large bowel has been dilated here, and even in here also. Here, how can I trace? Is there any way I can trace it? So the sigmoid colon has now is hugely dilated here, and if you see here also adjacent to it, there's a proximal dilated large bowel also here, also here. So this case, has been obstructed or been twisted from the mesentery, which caused sigmoid volvulus. So that the twisted loop of the sigmoid colon, if you see, it give the appearance of what we call it, calcification. If you look at here, this is, you can easily trace it here, and this is in the middle of it. It will give the appearance of the calcification, yeah? Just like it is the same one. This is just for educational purpose. Here, if you look at here, it is the it's the same. It's the left iliac fossa. To be honest, it's left to the midline. Here, if you see here, it's a dilated lobe, very hugely dilated, large lobe. If you look at here, if you could just trace it here, dilated large bowel. So it is in the ideally the cecum should be in the right iliac fossa, yeah. So this dilated lobe, which came just to the midline or to the left iliac fossa, which is the cecum volvulus. Although, usually you're gonna hear the sigmoid volvulus because the most common one, which can be twisted at its mesentery. Cecum volvulus, it's very uncommon. Because it not only occur in those congenital when it's partially covering the peritoneal wall. So partially it's covered with the peritoneal wall, partially not. When it's the part of this partial not covered, it might undergo to the twisting and volvulus. So this is one case of the cecal volvulus. Cecal volvulus here with the dilatation of the cecum part. Ideally, the cecum should be in the right iliac fossa, yeah? But if it's become massively dilated, it will come to the midline and might even extend toward to the left iliac fossa. Yeah, so this patient, it was only confirmed as cecal volvulus after went to the theater and during the laparotomy. But before it was only says that there is a large bowel obstruction. This is the same picture that has been traced just for you to know. So this is the cecum, and this is the small bowel. Just you can see it again. So this was the tracing of the dilatation of the small bowel, and this is the cecum, and this is the small bowel. Okay, so we've said that when you're if the patient come with the acute abdomen, and you're going to request the abdominal pain, usually what condition would the patient present with the acute abdominal pain? Either it be perforation or intestinal obstruction, whether it's a small or large bowel obstruction. And also, if the patient may present with the feature of colitis in the patient with background of inflammatory bowel disease, especially ulcerative colitis. Yeah. So if the patient present with the features of the abdominal pain, there's a screening of the patient with the inflammatory bowel disease. So other than the blood picture, you need to do abdominal X-ray to exclude megacolon or features of the colitis. So in the feature of the colitis, in patients with the inflammatory bowel disease like ulcerative colitis, what is the features of the colitis in the abdominal X-ray? Do you see this? Normally the bowel wall, there should be a continuity of the bowel wall and the large bowel, yeah? Yeah, here if you look at here a thickening, here the mucosal folds are very thick. You see this? So it gives us the sign of thump-like sign, yeah? So these are mucosal thickening of the bowel. It gives us the pictures of thump. You all heard about the thumping sign, yeah? Yeah, so why there's a thumping sign? Because when there is inflammation of the colon, there will be thickening of the mucosal fold. So these hastural fold are very thick here. It's giving us the appearance of thumb printing sign. Okay, here, same. Okay, if you look at here, the distance between balls of the lobe is increased. Why? Due to the thickening of the bowel wall. Because there's a thickening of the bowel wall, that's why you can see the distance lobes of the bowel. Okay, so this is one of feature of colitis or inflammation of the colonic wall. What we call it, thumb printing sign. Here we have another features of the, these all are features when there's an advanced stage of the ulcerative colitis. So you can see all of these features very common when you are working in the gastro department. So these are features of the advanced stage of the colitis, yeah? So this, how we are going to describe this? So this patient also non-case of ulcerative colitis present with these features of abdominal pain, bloody diarrhea. They were systematically unwell, feverish, high inflammatory markers. If you do an X-ray, suppose if you get this X-ray, how you're gonna interpret this? How? So if you look at here, this is a small bowel. Yeah, this is a normal small bowel here. You can see small central gas shadow. But if you look at here, the large bowel, it's a large bowel here, yeah? It's a transverse colon, hepatic splenic flexure, and then it comes down as descending. So how you're going to describe this? How? If you look at here, the transverse colon, the segment of the transverse colon, and splenic and descending one, it's like featureless, smooth, cylindrical shape. Yeah, it's like cylindrical shape. You can say a loss of the normal hastural marking. You know that the large intestine, it should contain the incomplete mucosal fold, the hastra circulation. Yeah, but here, can you see the hastra? No. Why? Because there is a loss of the normal mucosal hastra of the large bowel. Why? Because there's it has gone under huge inflammatory process of the colon. It lost its normal shape, becomes smooth, cylindrical, featureless of the shape of the segment of the transverse colon and even down to the descending colon. So this gives the appearance of what we call it lead pipe. Yeah, lead pipe. Here. As I said, if any patient come with the features of the abdominal pain, non-case of the arteriotomy, you need to do abdominal X-ray to exclude toxic megacolon, because toxic megacolon is this life-threatening condition. It characterizes the dilatation of the large bowel, of course, without obstruction. So this is in context of the acute bowel inflammation. Yeah. So what is the features of the toxic megacolon? So here, if you look at here, the colon is hugely dilated. Yeah, hugely dilated. If you look at here, so there is an evidence of the bowel wall edema. If you look at here, there's a bowel wall edema. Yeah. Why? How did I know there's a bowel wall edema or mucosal thickening? Here, if you look at here, we say there is a mucosal thickening here, bowel wall edema. So here the mucosal thickening, printing, what we say, printing, thumb printing sign. And here also there's another mucosal thickening, thumb printing, yeah. And also there's another feature other than, so, I mean, what's the feature of the toxic megacolon? Hugely dilated colon. For sure, it will be more than 6 centimeters, so it might reach 11, 12, 13.